on with my few comments, fitting, I hope, consistently with your theme. I spent a lot of time at the Centers for Disease Control. Had a really good time, learned a lot. Hope I left more than I took from the agency. But when I first started at CDC in the middle, late 80s, we would run around with 2x2s, those slides that we all carried around, and we carried our cassette and our carousel, and something always happened. It didn't work. And then we got the technology so we could use the PowerPoints, and something still happens. And as we refine the PowerPoints, what I've noticed is that folks reflect on the PowerPoint rather than on what's being said. So I don't have these slides. I don't know. You want to get Dr. Williams to get them from me, you can get what I have to say. You probably know it anyway. I'm pleased to be here at your annual Mercer Research Conference. I looked at the program last year, the theme, Workplace Violence, Best Practices, Research, and Trends. I suspect you had a good time. That sounds like a very exciting effort last year. This year's theme, Living in a Global World, prompted many thoughts in my mind about how to address this very important topic. But I paused as I reflected on the violence that is so pervasive and so blatant throughout this country. The continual killing of black males of all ages by white police is violence in its most disturbing form. An epidemiology colleague of mine who works at the NIH called me late Tuesday night, very, very upset as he watched on television a South Carolina police officer shoot 8 times a black man, hitting him 5 times in the back as he fled. The man died. I have a son, 3 grandsons, and a great-grandson. So I'm particularly bothered by the public health problem of violence. Yes, the public health problem of violence, particularly homicide. You see, I believe that violence is a public health problem that can and should be investigated using the tools of public health science. But it's not just a public health problem, I would admit. But I believe it can best be addressed using the tools of public health science, public health theory, and public health practice. You see, public health, as I've been taught and believe, focuses on prevention and promotion. What do we want to prevent, and what do we want to promote? The criminal justice system has failed. It cannot do it alone. That's quite obvious. We need to partner, and it's exciting to see this cross-disciplinary group of scholars, students, and faculty coming together to talk about common interests. We can't do it alone. While my NIH colleague was asking me, what he said was, is the incident of deadly force by police that we're seeing unusual? Or do we just now have the technology to capture it?
Yes. That's it.
I don't know, I'm just saying. For me, the question is that, can we turn this question into an hypothesis and systematically, if not scientifically, provide some answers? I think we can, I think we must. The horrible loss of human life due to violence globally is operating locally. While maybe not at the same magnitude, but needless loss of life is unacceptable anywhere and at any time. Think globally and act locally. I spent most of my professional life dealing with various levels of health and healthcare, which many times have little to do with engaging the health delivery system. We often think about health and then we think about going to the doctor. 85% of health has nothing to do with the health delivery system. no matter how good we think it is. I know that disease, dysfunction, disability, and premature death have no geographical boundaries. People who work in health and public health have learned to think globally and act locally. At least some of us have. In an ideal world, we also know that population health and well-being have the same potential of being without boundaries. We can be healthy all over the world. So we always work with both thoughts in mind. Think globally, act locally. See, I describe health very different than WHO. I describe it as a relationship, a dynamic, synergistic interplay between the physical, social, psychological, and spiritual elements that create the well-being of individuals and groups in their physical and social environment. You heard spirituality in that conversation. You heard the group in that conversation. You heard about a relationship in that conversation. You heard about the physical and social environment. That's what health really is, in my view. That's the context of and the basis of my comments this morning. However, we seldom report health statistics. More often, we provide and collect and report information on morbidity and mortality, grouped by various demographics. We often group them by race and ethnicity, by age, by sex and gender, by class, and or geographical locale. And we always find disparities, no matter, in almost all those dynamics. In fact, these disparities are chronicled in employment, in education, and unfortunately in incarceration, using the same demographics. People of color, except for selected groups of Asian Americans, die sooner or sicker than their non-Hispanic white counterparts. We have lesser educational opportunity, greater unemployment, and are mass incarcerated. Men are worse off than women. Low-income people are less healthy than other classes, and inner city and rural populations are less healthy than people who live in metropolitan and suburban areas. We are clearly living in a global world. But how does that impact on everyday people who live in local neighborhoods and communities, right here and right around you? Thus, the topic of my comments, thinking globally and acting locally. Think globally and act locally. Thinking globally, population data are integral to understanding the burden of ill health and current demographic shifts are impossible to ignore, especially in the developing world, as it becomes more urban and industrialized. In the U.S., the demographic shifts are aging, race-ethnic mix, educational attainment, and geographical locale. These changes are noteworthy. Life expectancy differs by 15 years based on where you live. Environmental justice. 10 years based on your income. Economic justice. 9 years based on your education. Educational justice. 7 years based on your race. It is embarrassing to be able to separate people in this country, all the world, based on your race, based on your education, and your income. Almost daily, health and social service systems, here and abroad, as well as systems of economic transaction, are being altered by population dynamics. The mass relocation of rural populations was a defining demographic trend in the latter half of the 20th century. The world's cities are currently growing at 4 times the rate of their rural counterparts. And at least 40% of their expansion is a result of migration rather than increase in natural development. I work in Tuskegee, and Tuskegee is rural, southern, black South. And if you're coming up in Tuskegee, ain't nothing to do. No TV outside of your home. No theater, no skating ring. Nothing to do but get in trouble. And trouble is easy to find, no matter who you are. Trust me, been there and done that. Rural to urban migration in cities without adequate infrastructure. If you want to stay in Tuskegee, what you going to do? Waste collection, disposal. What are you going to do? Affordable, high-quality housing. My gas bill, electric bill in Tuskegee is high, higher than Auburn. What are we going to do? Good public transportation. There's no such thing as an emergency in Tuskegee because there ain't no hospital. So if it is an emergency, you're not going to live. If you live, it wasn't an emergency. In the United States, the Hispanic and Asian populations each are growing faster than other population groups, according to the most recent Census Bureau analysis. The number of Hispanics in this country has increased 17%, and the number of Asians has increased 12.5% since the 2000 census. As of July 2013, there were 54 million Hispanics in the United States, making Hispanics the largest minority population in this country. Everybody knows that, don't you? If you don't, you ought to act like you do and learn how to speak Spanish. Black people are second with 45 million. The swift growth of the Asian population, many of whom are members of a working age group, 18 to 64, is less well recognized, but that population is growing as we speak. The number of people in the U.S. of Asian descent total 14.2 million as of the mid-2012, up from 2 million in April 2000. Less than 1% of the U.S. population is Native American or Alaska Natives. Hear that again. Less than 1%. According to the Census Bureau, about 4.3 million people list themselves as being of one or more race. That's so funny to me. One or more race. My great-grandmama was Native American. My father's side, I don't really know. But I always thought I was black. But now I can be black, Native American, European American. The more things change, the more they stay the same. The gap between the haves and have-nots is growing. The gap between education and less education is widening. Ill health, in many ways, is the prototype for inequities in well-being and quality of life. If you're sick, you can't do much else. So health becomes a measure of the well-being of the individual, the group, and the nation. Health, like disease, has no geographical boundaries. If you limit your thinking, in this instance, your research thinking, to the global community, you will miss both the challenge and the opportunity that are right here before your eyes. If you don't believe me, go over to Buford Highway in Dover, and you will see the global community right before your eyes. People of all sorts, dress codes of all sorts, foods of all sorts, and cultures of all sorts, right before your eyes. Both good and bad, the assets and the deficits, right before your eyes. We are global without even leaving Atlanta. We are global without even leaving Atlanta. So what do my earlier comments about thinking globally and acting locally have to do with research. Since this is a research conference, is it not okay for you to continue your global research efforts? Well, yes, I think it is. In fact, I think it's imperative that national and global research efforts continue. However, if you put on an ethical lens, a right and wrong lens, the ethical problematic is easy to discern. People in local areas are deprived of the opportunity to reach their highest potential and be their best self because of barriers, many of them health barriers, which impede their growth and development. The people in local areas do not have equitable access to benefits and the genius of human-centered research and the healthcare delivery. Thus, they disproportionately suffer from preventable diseases. It is unethical for people to die from preventable causes. Period. The U.S. is among the richest countries in the world. Yet the health disparities, health inequities are embarrassingly high. The dollars spent on what is a sickness system don't match the health care and healthcare opportunities and the outcomes that should be expected in the United States compared to other parts of the world, particularly industrialized countries. The United States must do better. We spend more money than anybody else, but the data are clear. The outcomes are not equal to anybody else. Let's be clear, however, I applaud the wonders of biomedical or basic science research. But right here on the ground, in the local community, how is that research translated to improve the lives of the community? That's the empowering question. Some scientists argue that it is not their job or their career path to improve local health. That's fine. That's not your goal. That's not your focus. That's fine. But whose job is it? Is the empowering question. Who's going to do that job? I worked at NIH for a couple of years ago, and I remember the mantra, from the laboratory to the bedside. Sounded powerful, from the laboratory to the bedside. Well, even with the passing of the Affordable Care Act, many people don't have access to health care, much less to a hospital bed. So just going to the bedside is not enough. I suggest we expand that mantra from the laboratory to the bedside to the community. If we focus more research on disease prevention and health promotion, we may probably bypass the hospital bedside anyway. You know, in communities where I've worked, you go to the hospital to die. Is that what happens? In communities where I've worked, you go to one hospital, and if you don't have health insurance, they send you to another hospital to die. So the community rumor is you go here to live, hospital X, and you go here to die, hospital Y. That's what the data say, but that's not what the data mean. Let me suggest one research strategy to address what I believe is an ethical problematic of bypassing the local community. That strategy is community-based participatory research, which acknowledges the importance of biomedical research, but it also considers a population focus aimed at the physical, social, psychological, and spiritual dimensions, as well as structural and physical environmental inequities. It's much broader than one domain of research. The approach demands that active involvement of community members, organizational representation, and researchers in all aspects of the research process. The CPPR process is a scientific inquiry that is conducted in a partnership between the traditionally trained practitioners and the lay participants. In CBPR projects, the community participates fully in all aspects of the process, from the beginning to the end, including the publication. The expert practitioner and the lay practitioner are co-equals in the CBPR project. The method requires that the views, concerns, and interests of all participants are given equal weight in determining the focus of the research question, the approach to employ, and the attempts to resolve. So you're just not asking for input. I want your input. No, I want your authority. Very different paradigm. The work in CBPR combines three activities: investigation, learning, and action. It is a method of social investigation of problems involving participation in problem formulation and resolution. It is a learning process for the researcher and the participants who analyze the structural causes of named problems through collective discussion and interaction. That means working very closely together. Finally, it is a way for researchers and lay communities to engage in a concerted action, both short and long term, to resolve fundamental problems. The direct link between research and action is a unique aspect of participatory research. By combining the creation of knowledge with concrete action, the traditional research dichotomy between knowing and doing is resolved. Knowing and doing become one and the same. To know is to do. The translation of knowledge is imperative, but not enough. CBPR is intended to improve health immediately, not long term. You see, I believe health is undergirded by human subject research, which is essential in health and health care for groups, for individuals, and for communities. However, the concept of health must be translated and seen as a relationship, a dynamic, synergistic interplay between the physical, social, psychological, and spiritual elements that create the well-being of individuals and groups in their physical and social environment. It is a relationship, dynamic. You can be healthy one minute and get some bad news about some family folk and be unhealthy the next minute. It's happened to me, and I'm sure it's happened to you. It's dynamic. Let it be. Sustaining health is essential if the human condition is to improve. Let me give you a prime historical example of research efforts conducted with so-called good intentions, but faulty process. The father of gynecology, J. Marion Sims, MD, purchased black slave women to conduct research without anesthesia because he supposedly believed that these women could not feel pain. Other white physicians tested remedies of heat stroke by forcing black people to work long hours in the sun to determine if their remedies worked. In the North, cadavers were stolen from black cemeteries and used in medical school. I never thought about the cadavers that I was dissecting when I was in dental school. I didn't think about where they came from. I was just trying to learn about the anatomy and where the muscles. And I never thought whose relative that was or where that cadaver came from. I didn't think about it. I'm just saying. A series of human subject research encounters with documented bioethics violations include, but not limited to, the following. Human radiation experiment during the period 1944 to 1974 in this country. Thalidomide studies used for clinical trials in the U.S. County in Europe, 1957. Willowbrook State Schools for Retarded Children allowed these children to be injected with a mild form of hepatitis serum to help develop a prophylaxis for hepatitis, 1956. Brooklyn Jewish Chronic Disease Hospital injected liver cancer cells into elderly black patients, 1963. Nazi experimentation during World War II conducted on people thought to be inferior, Jewish people. The U.S. Public Health Service syphilis study at Tuskegee, 1932 to 1972. The Guatemala syphilis study, 1942 to 1947. They say in Tuskegee they did not inject the men. That's what they say. That's what the evidence suggests. But in Guatemala, in 1942, they did inject the men. Same scientists, same agency. I'm just saying. The so-called research studies were all purportedly conducted to improve the human condition through the acquisition of new knowledge. Benevolence, they called it, the intention to do good. This is a presupposition that undergirds human subject research. However, benevolence, as documented in the previously listed set of research studies, occurs during the 19th century and 20th century, all too often, was the result. All of the previously listed studies document bioethics and public health ethics violations. The U.S. Public Health Service syphilis study is the worst. 40 years, non-therapeutic investigation. The infamous study. 623 low-income, lesser-educated black men living in rural Macon County, Alabama, were unknowingly involved in a so-called study to determine the impact of syphilis on organ systems. The men were denied treatment for the disease even after the effective treatment, penicillin, was discovered a few years later. There were no written protocols in that so-called study. Nothing was written. And by 1936, they knew everything they needed to know about the impact on the organ system, published in referee journals, so everybody knew, I guess. But the study continued until it was exposed, not by the scientific community in 1972, but by the New York Times. You can get the painful details of that study from the book I edited, so I won't belabor that, but it's all well documented. A friend, colleague, Ralph Katz, a dentist, PhD epidemiology, and I edited the book to really get at the truth, whatever the truth may be. In 1997, at a White House ceremony, President Bill Clinton apologized to the men and their families, the African American community, and the nation. He also mandated that the National Center for Bioethics and Research in Healthcare be established, which is where I work currently. I provided an article that details that history for your review, published in 2011. I hope that you understand, if you intend to live in a global world, which we have no choice, we must do, then we must think globally. Hope that's clear. But I hope you also will consider acting locally as well. But acting locally is not easy. Any of you who have worked in community know that's hard work. Folks don't like you, they don't trust you, you can't get nothing done, there ain't no money, people got things to do. You know what I'm talking about, particularly you nurses, you know what I'm talking about. But acting locally is important. Given the history of ethics violation, local folks don't trust you. Do you blame them? It ain't personal. Well, I don't know. I don't trust you either. I always get a second opinion when I go to the doctor. Always. It's not, it ain't personal. I just do.
I'm going to tell you.
That's right. And I'm at the time of point in my life where I need a geriatrician, so I always check with Dr. Shamita Williams. Just an aside, I have what you call tennis elbow. I don't play tennis. I went to my family physician and good doctor. And he said, I don't know, but I would refer you to an orthopedic surgeon. And he took an x-ray, whatever he did, and he said, you have tennis elbow. So I just said, And he gave me a shot of cortisone or something, and he said, well, that should take care of it. About 2 months later, came back, on play tennis. I went back and gave me another shot. He said, that should take care of it. So, okay. About 3 months later, came back, I went back and he said, well, Dr. Warren, we can give you a third shot, but after that we have to do surgery with only a 50% chance of recovery. I appreciate his honesty. So I went over on Buford Highway and found me an acupuncturist. Been going there for 4 months. I don't have tennis elbow anymore. I'm just saying. My primary physician examined me because when you get a little older, they examine you more often and come up with more tests. And he's good. He said, well, I don't know what I think you have a abdominal hernia. Sounds scary. He said, but I'm not sure you want to get anything done about it. But I'm going to refer you. That's what I'm supposed to do. So I was referred to a surgeon, and he was a gentleman around my age, looked like. He works for Kaiser. He's in the system. He gets his check regardless of what he does. So he said, well Dr. Warren, I have a hernia, and I'm not having anything done with it. He said, and I don't have any car note to pay. It ain't hurting you, so I wouldn't bother it if it doesn't bother you. I'm just saying. In many communities, and I also had a callus on my foot, so my primary doctor referred me to a podiatrist. And that was, I'm going through the system, all the things that you get that this system allows. I was going through all of it. And he just said, look, you stop wearing the hard shoes. Don't wear hard shoes and go see a chiropractor because you need an adjustment. I mean, it was powerful. I'm going right now. When I went to see the chiropractor, he started popping on my back. And he popped on my back and then put me on this thing and just massaged the back. So I went to 4 different practitioners, all doing something different. All doing something different. I have that access. I have that privilege. And I'm not sure which one of them is working. But you know what? It really doesn't matter. I don't have tennis elbow. I have no callus on my foot. The hernia is not bothering me. And all is well. That's what I'm talking about. That's what the United States affords some of us. And I say that jokingly, but for many of us, we don't have any of it. That's the ethical problem. Now, in the interest of time, let me move on so we don't get caught up. In many communities, the word research is bad. In Tuskegee, the word research is frightening. Don't mention that word research in Tuskegee. We need a new way of thinking and acting, I think, if the research enterprise is to grow. IRBs are good, but they're not good enough. Trust me, after a while, everybody in the IRB starts acting the same. The community representative all of a sudden has a sophisticated way of analyzing research. And they got a clue about research. They lose the reason for them being there. We've got work to do. Stop trying to solicit trust, colleagues who are researchers. Demonstrate trustworthiness. Very different. The burden is not on those who you want to engage. The burden is on you to demonstrate your trustworthiness. When you prove yourself trustworthy, trust will follow. When you prove yourself trustworthy, trust will follow. We also need a new language. We need a language that embraces ethics in a manner that requires transparency and demands authenticity. Let me provide a few examples, because President Clinton, when he apologized, said what was done was wrong, morally wrong. Now, you heard when Dr. Williams introduced me, I have a lot of degrees. I'm a very, very slow learner. He was not one to say that. But that's what the deal is. But I have a bachelor's in biology, a doctorate in dental surgery, a master's in public health, doctorate in public health, teaching fellowship, clinical fellowship, and I never heard them talk about right and wrong. My course in ethics was a sham. How to stay out of trouble, how to keep from getting sued. What not to do to keep from getting in trouble. So I never heard words like right and wrong, like fair and unfair, until I went to seminary. And then they told me to pray over it. That wasn't enough. So let me give you a few tools as I conclude. There are many ways to define ethics. I have one that fits for me and fits for Tuskegee. Ethics is a set of rules, principles, values, and ideals of a particular group of people. The systematic study of morals, concepts, and theories, typically in departments of philosophy. The operative part is a particular group of people. What is ethical to you may not be ethical to me. I don't have to live with your ethics. The folk that were engaged in the syphilis study, I suspect some of them thought it was ethical. The men didn't, and their families didn't. I don't think it was then, I don't think it is now. But it's not necessarily your ethics, it's my ethics. We can agree, maybe not agree on what's right, but we surely can agree on what's wrong. That's easier to do. Let's work on not doing wrong, rather than figuring out what is right. Ethics evolved out of philosophy, departments of philosophy, but you know, philosophers many times want to just talk and talk and talk and talk. It's important to talk, but we got to move from talk to action. Bioethics, applied ethics, focus on the doctor-patient relationship and how the changes in the healthcare system affects it. Somebody's master's thesis or doctorate dissertation ought to be about the Affordable Care Act. I would argue it's not economic, it's not access-driven, it's ethics-driven. But somebody ought to find out. Public health ethics, population-based. Public health ethics emphasizes the ethical problematic related to the intersection, the interests, and health of groups, and social justice of the distribution of social resources, and the positive or social rights of individuals. Social justice, social action. That's public health ethics. You've heard the word health disparities, probably to the point where you're sick of hearing it. When I was at NIH, they said it was just a difference. No. It's more than a difference. It's the difference between groups of people who have different relative positions in social hierarchies according to wealth, power, and prestige. Those with more money are better or healthier. Those with more power are healthier, and those with prestige are healthier. Those without have the health disparities. It's about inequalities. Health equity. Ideally, everyone should have a fair opportunity to attain their full health potential and move pragmatically that no one should be disadvantaged from achieving their fullest potential if it can be avoided. Everybody should have the opportunity to be their best self, whatever that is. Whatever your best self is what you have the opportunity to achieve. Let me conclude with three kind of quotes that put my whole comments, I hope your research enterprise, in context. One was from Secretary Margaret M. Heckler, who was the secretary of HHS when the Secretary's Task Force report on Black and minority health was published. And she said, and I quote, "There was a continuing disparity in the burden of death and illness experienced by Black and other minority Americans as compared to our nation as a whole. That disparity," she wrote, "has existed ever since accurate federal record keeping began, more than a generation ago. And although our health charts do itemize steady gains in the health of minority Americans, the stubborn disparity remains an affront to both our ideals and to the ongoing genius of American medicine." She said things are better for everybody, but the gap is getting worse. That's what Margaret Heckler said in 1985. Just as an aside, there were 60,000 excess deaths in 85. That is the gap between deaths among Black people and their non-Hispanic white counterparts. In 2005, that number had increased to 83,000. Don't get it twisted, we're going the wrong way. In 1896, W.E.B. Du Bois, and if you don't know who Du Bois is, just shake your head like you do, interviewed 5,000 people in a study on Black people, in a study on the conditions of Black people, visiting churches, businesses, social and political gatherings, schools and homes. His findings were published in a 1899 book entitled The Philadelphia Negro. Du Bois found that the chief problem of the Philadelphia Negro was not that of sheer ignorance, but a lack of education. Black family life, he said at the time, needs strengthening at every point. That was in 1899, and in 2015, that ain't new. And lastly, this is the 100th year of the death of Booker T. Washington, the founding principal and president of Tuskegee University. And those of you in public health or just in health in general know that every month, the month of April, is Public Health Month. And the nation celebrates wonderful things that are going on in public health. A few years ago, they also designated that as Minority Health Month, because you can't separate public health from minority health. Well, let me read you this quote, which may be surprising to some. In 1914, Booker T. Washington, founder of the Tuskegee Institute, addressed the policies of the health of African Americans, and I quote, "At the last session of the Tuskegee Negro Conference, some startling facts were brought out concerning the health of the colored people of the United States. 45% of all deaths among Negroes were preventable. There were 450,000 Negroes seriously ill at all times. The annual cost of this illness is $75 million. That sickness and death cost Negroes annually $100 million. In 1915, President Washington started Negro Health Week. On April 17th, the Centers for Disease Control and Prevention, the Morehouse School of Medicine, and the National Center for Bioethics and Research in Healthcare at Tuskegee University is sponsoring a forum at CDC here in Atlanta entitled From Negro Health Week to Minority Health Month, 100 Years of Progress in Public Health. I invite you all to tune in, be there, or be online, and you'll find out something I hope that you didn't already know. Again, I'm excited to be here. I'm honored to be among you, and thank you very, very much.